Well, good afternoon. Janet, thank you for that more than gracious introduction. I'm really thrilled to be here. I was asked to speak under this imposing sounding title of Reframing Society's Perspectives on Aging, but it's very clear to me that you all are doing it. So that's extremely exciting, and I'm thrilled actually that Senator Blake just did it. Thank you. And that what I want to say, I think, is hopefully a compliment to what you were saying in both senses of the word. And I think this is a collective exercise we need to go through, and you're doing it. And I really am excited about where you're going and look forward to learning what you decide. So I often talk to undergraduate students. I even talk to them about aging, which is something that you wouldn't expect undergrads to sign up for, and they don't wittingly. But it's in the context of a global health course that we teach for Columbia undergrads, and the truth is that the entire world is experiencing longer lives. It's not just Scranton, it's not just the US, it's not just Europe, it's the entire world. And so I always ask them the same question. Picture sitting in a classroom, you're 20 years old, and this professor says to you, what if I could give you 30 more years of life? Would you want it? Would you take it? And the same thing happens every year. There are 100 kids in a class, 100 young adults. When I ask them to raise their hand, 98 of them will take it, and 2 vote no. And then I always ask the 2 who voted no, they're extremely smart young people, and I say, well, why don't you want this? And they're smart enough to deal in probabilities. And they usually say the same thing to me. They say, well, it depends. What does it depend on? I ask. And they say, well, it depends on whether I'm healthy or not. Enough said. So that's pretty important on their part. Now, supposing you could go into your own kids and say, congratulations, guess what I got for you? 30 more years of life. What would you do? Would you say, well, can you imagine what you'd do with it? I bet you would as a parent. You'd say, well, let's think about this. What are the options? And then you'd probably, as a parent, end up saying, well, how are you going to prepare? And that's where I think we all are right now as a society. If we're smart, we're saying, how can we prepare? Now, this is really an extraordinary and actually unprecedented moment in human history. I think, my kids are in their 20s. I think that they know they're banking on living till they're 80, which is our current life expectancy. They haven't, maybe because their mom's a geriatrician, they've thought about it more explicitly than other kids, but I think they're just anticipating it. Their grandparents lived that long, they see all these multiple generations and families, and so they're just assuming that's what's going to happen. And I think, and sometimes they admit that I'm right, that they are conditioning their behavior on that assumption because they are in no rush to grow up, as far as I can tell. They say, Mom, Dad, we've got all the time in the world. I don't have to commit to a career, right? The people here recognize that. Well, in fact, so I think that this life extension we are experiencing is being experienced heavily by young people without us talking about it or planning for it with them. And what do they need to know? What do they need to know if they're 20? What do you think? Well, we don't know. But it's going to be different. They're going to conduct their lives differently than if life expectancy was what it was in 1900 at birth, which was 47 years. Imagine that. A mere 100 years ago in this country, when you were born, you could expect to live only to 47 on average. What didn't we plan for in those other 30 years? A million things. Right now we've got lives that are partitioned. We go to school a lot for 20, 25 years. We work like crazy and raise kids for another 20, 25 years, maybe 30 years, maybe 40 years. And then we are now about to spend a third of our lives in retirement. These are highly segmented. We don't really know what to do with retirement. We haven't planned for it, really, as a society, and most individuals actually, it turns out, haven't planned adequately as well, and don't find the opportunities that they would love to find in the main. But what if we could mix this one all up and just create this immense collective or individual act of imagination and say, you've just been given 30 years extra. What will you do? What do you want it to be? Well, this is actually a question I would posit that we need to ask now for our kids and our grandkids, because it's going to take 30 years to construct the society in which we want them to grow old. And there is no roadmap on this one, because this is an unprecedented moment in human history. Never before in human history have human beings lived on the average to 70 or 80 or 90 or 100 years of age. Ever. We don't know how to do this one. And I would imagine that if we imagine the lives that we'd like our grandkids to be living when they're 80, it might free us up to think about what we want to create, which goes beyond budgets and deficits to what the right thing is to do for the society we want our kids and grandkids to live in. So here we are. Because of human investment, unprecedented successes of science and knowledge, over the last 100 years in the US, we have extended human life beyond what anybody could have imagined 100 years ago. Because of, in rank order, public health, creating the conditions in our population for people to be healthy across their lives, to survive childhood, to not die in pregnancy, to not get many communicable diseases, to live toward older ages. Because of that, because of poverty alleviation, because of education, and more recently in the last 60 years, because of medical care, we have created the opportunity to have 30, 40, maybe even 50 more years of life. So now we've got it. And I would say that is an amazing success of human innovation, investment, and endeavor, and we're declaring it a disaster. It was what we wanted. So before we declare it a disaster, we need to do what you all are doing. And we need to do it at the level of our cities, our states, our country, and say, is there opportunity here as well as necessity that we need to create that could make this great for everybody? It could be great for everybody. How do we do it? Well, I just gave a talk to my school yesterday saying that in the face of the financial situation this country's in, we will yet again cut expenses, pare budgets, but we're not going to cut our way out of greatness. We also have to invest. You got to do both, whether you're a corporation, a university, a state, a country, or you have no future. So what are we going to do? So we have the most astounding success of human achievement, and we don't quite know what to do with it. So is the gloom and doom we're imagining what we want? Is cutting out the floor of social protection for vulnerable populations, will that result in the society we want to live in, we want our children to grow old in? Probably not, I would guess. But we are having a little trouble looking at this. Now, for the medical people in the audience, I would posit that we have a disease. The disease I would posit we have around these issues is a scotoma. A scotoma is, as all of you know, a stroke in the optic nerve, which creates a hole in your vision, but you don't know the hole is there. And in our policies and many of our practices around the issue of aging, I think we have a scotoma. It's a very large scotoma. But unless we know and I think it's driven by very human responses to fear of aging and death, that's deeply human, and we avert our gaze at all costs from those topics personally and societally often. But if we know we have a scotoma, then perhaps we can either work around it or learn how to fill it in. That might be good rehab. So we haven't lived this one before. Where do we find the solutions? Well, there's another story, which many of you know. It's about lampposts. And guy's in the dark, it's nighttime, he's on the street, he's under a lamppost, feeling around under the car next to the curb, and a friend walks by and says, "What are you doing down there fishing around on the ground?" He says, "I'm looking for my keys." And his friend said, "Well, I'll help you. Where'd you drop them?" And the guy said, "Oh, they're over there in the park. I dropped them in the parking lot over there." So the person says, "Well, why are you looking over here?" He says, "Because this is where the light is." We tend, I would argue, to look for solutions where we know they have been, going to your Mark Twain quote. But in fact, I think we need to build some new light posts in new places. And again, remember what could be as an act of imagination based on our values and how we create the opportunities that might bring them forward. So tonight, I'd like to think with you about both the opportunities and the necessities in that regard. Not to suggest that I know the answers, but hopefully to stimulate our collective imagination. Today you have been talking with great imagination and great passion and great knowledge about how we meet the needs of the people who are already old. And of course, this area is at the leading edge of the aging of the US population. How we meet the current health concerns of current older people. How we understand how to use medications effectively. How we bring geriatric knowledge about the changes in the physiology of people as they get older. How it creates vulnerabilities and frailty and loss of resilience, and changes how goals are set. It changes and amplifies the complexity of care. It modifies the vulnerabilities of older people, and the goals and outcomes change. And you're talking about all that. And you're talking about the needs of caregivers as well as the needs of caregiving. All of those are absolutely critical. And we have to take what we now know, which is a lot, and make sure that everybody who is providing care either knows how to do it well for people who have the complexities of health and needs regarding health with aging. And we need to figure out how to translate the knowledge we have about how to keep people healthy and prevent many preventable things. When I was a fellow and a junior faculty member, which was in the 80s, It was just at the moment when science was discovering that cardiovascular disease was preventable into the oldest ages. We didn't know that before. We thought it was an inevitable consequence of aging, like senility, right? We know a lot now that the two are separable. Rates of cardiovascular disease and stroke in the U.S. have plummeted in the last 50 years, particularly mortality from cardiovascular disease and stroke. They've plummeted in the oldest age groups almost as much as they've plummeted in the younger age groups. We have learned how to do that. Prevention matters in every age and stage of life, and it matters into the oldest stages. So you were talking about all that, and I completely commend you for doing it. And we have to learn both how to know what we already know and how to set a course for figuring out the rest. And how to actually invest in the array of medical providers and health supporters who will be the teams we need for an aging population in the future. There are many courses in cardiovascular disease prevention which are entirely focused, for example, on people in their 30s, 40s, and 50s. What proportion of strokes occur in people over 65? 68%. So prevention could really, really matter on a devastating disease if targeted appropriately and effectively to older adults. And similarly, how we expand our workforce so that we have geriatric medical knowledge, nursing knowledge, social work knowledge, and public health knowledge, and we have them working in a system that knows how to deploy them, which I might add would be less costly than the system we now have. It would be immensely less costly to our nation and to our states and our cities and to patients and their families. Now, how do we do it? Well, I think part of our societal scotoma has led to the fact that we have not invested in creating a health workforce that actually has the expertise to care for older people. I had the privilege of going on a trip to Cuba 3 years ago and discovered that Cuba has 657 geriatricians on the island of Cuba, 657 geriatricians. The US has only 10 times more than that. We have not invested in our future needs. Now, it's not too late, but it could be if we keep waiting. And once we educate a workforce, we're going to need to invest in designing the system that enables them to provide the care that would improve outcomes and lower costs. After a number of years of running a highly developed geriatric medical system at Johns Hopkins, I can tell you that that's true, it does. It provides better outcomes at lower costs, particularly if targeted to the subpopulation of about 20 to 30% of older adults who are frail. Frail with dementia, multimorbidity, cognitive decline, and at the end of life. But we have to invest in training people so they have the skills to effectively manage and care for both those patients and the people who love them. At the same time, I would argue that, and this is probably a little radical, but I would argue that a geriatric medical system and the principles of it actually would turn out to be very good for every age, because it's a continuum of medical care that is really well designed to be targeted to the health needs of the individual, that evolves over time as their health needs change, that incorporates prevention, that involves team-based care as the complexity of care needs increases, and that goes from hospital to clinic to community to home in terms of the site where people could benefit from care. I don't know about you, but I had many patients over the years who were too sick to come into the doctor. You know, they'd say, "Oh, doc, I would have told you, but I was really too sick to come in, so I didn't let you know." I mean, what kind of a system is that? But I would also say that we need to develop the public health side of that system also. Why? Well, it's for our kids and it's for our current population of older adults and our kids when they are older. Because 60% of health in our communities and our societies are created through population-based approaches and public health. 60% of health. And we know enough now about prevention to know that investing in prevention at every age and stage of life is likely to lead people to turn old healthy. But not making those investments at every age and stage in life will lead to our fear, which is that we're going to grow old, but we won't be healthy while we're doing it, which was what those undergraduates want to opt out of. So we know how to do it, but we have not built a public health system that is financed, trained, or equipped to do that. And it would be a very wise investment. That has to do with preventing what we call non-communicable diseases, chronic diseases, cardiovascular disease, stroke, pulmonary diseases, diabetes, hypertension, etc. And it has to do with maintaining strength, resilience over one's lifetime to prevent the development of frailty. And hopefully it will include the approaches we take to preventing cognitive decline and dementia, which is a really pressing need. Now, we actually invest in preventing cognitive decline. We invest a lot because it turns out that the #1 predictor of dementia is educational level. And so I just want to point that out because everything is connected. So we have to train a new generation of health care workers in every discipline. We have to train them to understand how to pass to each other because for older people, it's in the passing from hospital to home, from one provider to the next, that people get lost and bad outcomes happen. We need to be financed to think as a team, and we need to understand how to take care of the vulnerabilities of geriatric populations with better quality and lower cost, and how to make use of geriatrically expert health professionals in that mix. But we also need a system that helps you do it. You can know how to take care of frail patients, but if you have a system that is not designed even to see frailty as a diagnosis, it's really hard to do. And and by the way, I'm very pleased to say that there's an international consensus conference that is about to report out that frailty should be a medical diagnosis and will be considered by geriatrics as a formal medical diagnosis. But you have to have a system that is organized to provide the kind of care that older people need, and we're not there. So I hope this complements, and I think it complements, what you all are already discussing, imagining, planning for, which makes a profound difference. But to complement that, and to reframe aging, I think we need to think beyond the boundaries of medical care and even beyond the boundaries of public health to ensure well-being of our population across the life course. That starts with something this country did very wisely in 1932, ahead of the curve of almost every country in the world, although almost every country in the world is now realizing they need to emulate us, and that was to create Social Security. Social Security was designed in 1932 and put into law as a family policy. So we have lost our history in large part. Social Security was not a giveaway to old people. Social Security was not designed for old age dependency. Social Security was designed to be a family policy to ensure the preservation of the living standards of working age people who are working very hard when they needed to do the right things by their parents. Social Security was a policy for working age people. It still is. It's a family policy. That's why it's the most valued program in this country. If Lynn Feinberg was still here, I know she spoke earlier, she would say, and I concur, that there are easy fixes to Social Security if we just move the retirement age back 2 years. It's not a hard fix at all. But the important point for this discussion is how much social protection policies matter for every age, for every generation. Social Security is just one of them. But how we ensure a floor of well-being for people at every age and stage of the life course is the mark of a civilized, humane, and cohesive society. And how we navigate these very choppy waters of moving to a new longevity in our lives, creating a new part of the life course, this extra 30 years we just added, and renegotiating our social compact so that we end up stronger together, not divided against each other, is really critical. And it's going to require great leadership to get there, and great conversation, great imaginings like conferences like these, and the ability to think together about who we want to be for our kids. Because that's what this is about. So I want to add, beyond medical care, beyond public health, beyond social protection approaches for the vulnerable, which matter tremendously, Social Security took older people out of poverty in this country and preserve the living standards of their working age kids. Let's think what else we're going to need to imagine in the coming years and invest in before we have to do mop-up or before we lose the opportunity that we could have created. Well, one investment actually has to do with something else Senator Blake brought up, which is our environments, housing. How do we plan, how do we anticipate the housing circumstances that we're going to want to live in as we get older? Most older people want to stay in their homes. Sometimes they can't, but most of them would like to. How do we design for longer lives? Well, actually, the American Institute of Architects is all over it. Businesses are all over this. They know we better plan for this. And they know also, increasingly, certainly the AIA knows it, that we want to design whole ranges of kinds of housing. Because in fact, most older people don't want to end up in a community of just older people because they want to stay in society. They want to stay engaged. They want to mix with people of all ages. They want to be part of a community. They're not ready to give up being a human being in a world that they care about. So how do we design housing to foster that while people can age in place? How do we design environments so people can stay active and engaged? We can facilitate that. We can facilitate that. I'm very proud to be on Mayor Bloomberg's commission to create New York as an age-friendly city. It's a very exciting enterprise in which we get to imagine things which haven't happened. And New York's pretty age-friendly, actually, unless you go in the subways when there's nobody over 60 there, except me. But these are the times when it's time to ask that. How do you design your pharmacy so that older people can go in there, the lighting can be good enough to see what they need to find? What they need is not all the way on the top shelf, so everything will fall on them when they go to get it. And there's a place to sit down and a bathroom to use. Those are your major customers. How do we design for your major customers? How do we design our streets so that older people can be safe, so they won't fall on broken sidewalk, and so that they can stay active in walking around and afford transport so they can stay engaged? These are all the questions ahead of us. I'm sure that you all have tackled many of them, but the question is, what's the universe of things? And the secret is that there's nothing about the medical care scenario I've told you about, there's nothing about the public health scenario I've just told you about, there's nothing about the housing scenario I've told you about, and there's nothing about redesigning our business and city environments I've told you about that doesn't turn out to be good for everybody else too. That's always the bottom line here. If you're pushing a baby carriage, it is really nice to not have to do it on broken sidewalks. All of these things are better for everybody, and it's like the old story about the canary in the mine. And I would imagine Scranton knows a lot about canaries in the mines. If you take the story, for those of you who don't know, this, miners thought that if you took a canary down into the mines, if the canary died, you would know that the air was not good for anybody. It's just the canary would die first. The same is true in some ways when you're thinking about vulnerable older adults or the needs of older adults. They point the way to how we design environments, cities, housing in ways that actually would turn out in the main to be good for everybody. And they create all of these questions, this imagining creates huge business opportunities, huge opportunities for technology and investment, for imagining a better design for communities that are walkable, livable for all of us. So this is not an either-or scenario. Either we invest in our old people or we invest in our kids. It doesn't have to be that way. We can find the points of mutual benefit 90% of the time, including in the design of a health system that's good for older people. It would be good for everybody else. You don't have to use all of it for everybody else. It's there. Disabled kids often need the same thing that disabled older adults need. Not always, but often. So there are some universal design features that could be drawn from the knowledge of how to do geriatric medical systems and provide geriatric expertise that could be good for everybody. But I'm going to end with one other example, which I think is really critical. And it starts actually with our major policy ratio in this country. The ratio that is driving many of our policy decisions is called the Old Age Dependency Ratio. It's the ratio that says that we can't afford all these old people because the most important equation in this country is the number of old people in our society compared to the number of working age, with the assumption that every old person is dependent and every working age person is able and working. Now, what's wrong with that equation? Well, a lot, right? First of all, only about 20% of older adults are disabled enough not to be engaged, maybe 25, depending upon what statistics you look like. Only 5% of the US population over 65 is in nursing homes. So clearly this, even if that was all you were thinking about, this major policy driver in our country is an anachronism. Because as the front cover of numerous magazines tell you, 80 is the new 60 and 60 is the new 40, we aren't aging the way we used to. So I think that this anachronistic policy expression is driving us into some policy decision making, including perhaps what's on the front pages of the paper today and yesterday about Social Security, which may actually not create the society we want our kids to grow old in. Now, if that's true, and you think about the policy decisions we're making, and it's predicated on, and this is a quote from today's paper, either we give the money to old people or we give the money to our kids. If we put it in one, we're taking out of the mouths of the other. This is an old equation. It's been around for about at least 40 years. But it doesn't have to be that way. And I deeply think that it requires our imagination to imagine the positives, to be able to create the positives to balance out the needs. Because it turns out that every single myth about these either-or equations we have turn out not to be true when you look at the data. It is not true that if you hire older people, you'll take jobs away from young people. That is not true. It is not true that if older people are working in the same place as young people, that productivity is somehow off. It's the opposite. Intergenerational teams are much more productive economically than single generation teams. I can go myth by myth by myth. They're not true. But these are our fears. These are our predispositions. These are the drivers of our scotoma, if you will. So what if we imagined the opportunities? What would be great if you were 70 and 80 years old? What would you love to be doing? What would matter? I have seen more patients who came in with a clinical problem whose real reason for feeling bad turned out to be that they had no reason to get up in the morning than anything else. And I used to write them prescriptions because I didn't know what else to do, and I actually was trained in physical activity prescriptions. I was used to writing them, so I used to write them prescriptions, and I'd say, I understand why you feel so bad. You're feeling like there's no meaning in your life, nobody values what you're doing, you have no reason to get up in the morning, there's nothing, you feel like there's no place to feel productive and engaged. So I used to write a prescription that said, go find something that matters and do it. And report back. And 9 times, this is in the 80s, 9 times out of 10, my patients would come back with their prescription unfilled because aging in this country, the 30 years we haven't prepared for, is a role-less role. And there were CEOs who were put in a corner to lick stamps. There were volunteers in school who were sent to Xerox papers. A lifetime of experience, and they couldn't find a way to make use of it and to contribute. And one of the defining elements of successful aging, of maturation over one's lifetime, is that in one's 60s and 70s and 80s, it really, really matters that you made a difference on this planet. It really matters. And so we have a profound mismatch here of the only increasing natural resource in the entire world, older people, the only increasing natural resource in the entire world who want to give back, who want to make a difference, who want to stay engaged. And in fact, they will be healthier if they stay engaged. And I'll tell you the reasons why in a second. And we have not planned for how they could do that in a way that would matter. And from my point of view, we have a few unmet needs in this country. Unmet needs where wise, mature, social capital dedicated to leaving the world better could actually help. So how do we solve this? Well, I'll just add on the health side that it turns out, if you look at the data, that if you don't have a reason to get up in the morning that matters to you, if you don't feel productive, if you don't have any structured activities in your week besides TV, that's actually a huge predictor of dying. Huge. If you don't stay physically active, if you aren't socially engaged, if you're isolated and lonely, those are all huge predictors of dying. And there's increasing information that if you stay cognitively active, if you stay physically engaged, if you are socially connected, if you feel valued and productive, you not only live longer, but you're less disabled and you feel better. Pretty interesting. So I'll just end by giving you one example, because I think when I said in the beginning that we need to commit some great acts of imagination to figure out the immense opportunities of an aging society, this is one of them. And that one of them is what I said, that everything older people need in general would benefit everyone else if we invested in it. And the second is that we need to create roles for older adults where they can make a difference, the difference they want to make, and design it in ways that are good for them and good for society. The program that Dr. Townsend mentioned that I've actually spent 25 years designing, bringing to fruition, shepherding, Experience Corps was designed to be the first and a model of what that might look like. That the world is not an either-or world, and older adults trained, deployed in public elementary schools to improve the outcomes for the kids can truly do it. They're not competing with paid jobs. They're not taking away the roles of teachers or teachers' aides. They're bringing the additional social capital into the schools, trained, deployed to meet what the principals say are their greatest unmet needs for the kids' success, and they can do it. And if you want volunteers who will show up and stay longer than anybody ever expected, those will be your older volunteers. And if you design these programs as volunteer programs, although there have to be particular design elements to make them work, as paid work to keep people getting some income as they get older, the return on investment is very, very huge. Certainly for the future of our kids and potentially for the health and well-being of an aging society as a community-based social model for investing in health promotion for older people when prevention still matters hugely. Thank you very much.